Hello, everyone. Welcome. Thank you for joining today's webinar, Exploring Other Dementias, Lewy Body, Frontotemporal, Vascular, and Mixed, presented by Home Instead and hosted by the American Society on Aging. We will begin shortly, but first, let's cover a few important notes. If you are looking to get a certificate for today's webinar, whether for continuing education credits or just a certificate of attendance, you can click on the tab labeled Certificate Application at the top of your screen. When completing your application, be sure to select a certificate type. This is called a credit reporting organization, and you'll have to click Add Membership. That doesn't necessarily mean that you need to be a member of this specific accreditation board, because we know that accreditation boards can accept continuing education from other providers. It's just a way for you to make that selection. And your license number will be labeled as your membership number. If you do not make a selection, then no certificate will be generated because the system won't know what it is that you need. The on-demand recording for today's webinar will be available in your classroom within 48 hours. And there are checkpoints during the webinar to ensure active participation. So be prepared to respond to these as they occur. And also, we've heard that sometimes if you have the screen in full screen view, you may miss the checkpoint. So we advise that you don't do that to ensure you meet all those checkpoints as they occur. For more information, please review the FAQs document linked in the Announcements tab right below this window. And you can also find it in your classroom and on our webpage if you need to reference it again. Presentation slides are in the Material tab. Feel free to download them now, or you can access them later in your classroom. Ensure you're logged into the webinar with the email address you registered with, or we have no way of tracking your attendance. Your time is logged, and you must view the entire webinar and complete the checkpoints to be eligible for certificates. You have 60 days from today to complete your application. For technical assistance, please use the helpline or chat available under the Help tab at the top of your screen. For questions about today's presentation, please use the Q&A tab below this window. We'll do our best to address these in the last few minutes of today's webinar. And now I would like to introduce today's presenter, Lakeland Eichenberger, gerontologist and caregiving advocate at Home Instead, with a doctorate from the University of Nebraska. Lakeland is a renowned speaker and expert in elder care. Lakeland, we're so excited to have you here today.
Thank you so much, Victoria. Hello, everyone. Thank you so much for joining me. It might be a short week for you if you had Labor Day off, so I hope you enjoyed the long weekend, and again, just appreciate you taking time out of your day to learn with me and about a topic that doesn't get a lot of attention. We're talking about exploring other dementias. So of course we know about Alzheimer's disease. It gets talked about the most of all the different types of dementia, and not much attention is paid to the other types of dementia, of which there are a variety, and we'll talk more about that in just a bit. So I am glad today that you're here with me to focus in on the other types of dementia. We'll be talking about how they're different from Alzheimer's. We'll be talking about some of the characteristics of the types of dementias, how they present, the symptoms, the signs, and then we'll also talk about some care tips that might be specific to the various types of dementia. And the saying is, if you've met one person with dementia, you've met one person. And so while I'm going to go through these various types of dementia and talk about them kind of in generalities, the symptoms that present in an individual might be different from another person with the same type of dementia. So we do need to keep that in mind, that the presentation of the symptoms of the type of dementia might look a little bit different, but it can be helpful from a professional standpoint, from a family caregiver standpoint, to understand what are the common symptoms that I should be looking for, so that I can know how to best approach the care for that individual. Also, when it comes to the diagnosis of these types of dementia, it can be helpful to get a specific diagnosis. Sometimes you might hear of somebody being diagnosed with dementia, and I often say, well, did they tell you what type of dementia? Because that can impact how the person receives treatment and care, and also how they're going to need perhaps different types of support along their diagnosis journey and along their journey living with dementia. So we have a lot to cover today. We're going to dig in, and these are our objectives. We're going to talk about what is dementia, because sometimes there's even just confusion around that term alone. Then we're going to go into these types of dementia that you see listed here: Lewy body dementia, frontotemporal dementia or frontotemporal degeneration, FTD, vascular dementia, and mixed dementias. And so within each of those buckets, we're going to talk about the unique challenges and characteristics, and then also some of those tips and support and resources to help individuals and their families who are impacted by these various types of dementia. And so before we talk about the term dementia, there's also another common term, a common diagnosis that kind of gets thrown into this mix, and that's MCI, mild cognitive impairment. And I wanted to talk about this because, again, it gets kind of tossed out there in this conversation of cognitive impairment. And MCI is not dementia, mild cognitive impairment, but it's also not a normal part of aging. As we get older, we do experience changes in our cognition, but MCI can evolve in a person, and it can change the individual's cognition in some subtle ways. They might have mild changes in their thinking abilities that are noticeable to the person affected and their family members and friends. However, these changes don't always interfere with that individual being able to perform their daily activities. And so people with MCI, especially those that have maybe memory problems, as part of their MCI, they might have a higher risk of developing dementia than those without mild cognitive impairment. But MCI does not always mean somebody's going to develop dementia. Some individuals, they might even revert back to normal cognition, or that MCI, that mild cognitive impairment, can remain stable. So again, a diagnosis of MCI does not equal dementia. It could put them at a slightly higher risk of developing dementia, but it also might mean that they do not go on to develop dementia. So I hope I haven't confused you right off the bat, but I think it is important to understand if we're seeing any sort of change in an individual in terms of their cognition, we need to bring those changes to their healthcare provider so that those changes can be tracked. Because if somebody, let's say, does have mild cognitive impairment, that is something that the medical provider is going to want to keep an eye on to make sure, okay, if it does develop into dementia, then we can modify the treatment and the support for that individual. So it is important anytime there's changes in cognition to bring it up to the healthcare provider. So now let's talk about the term dementia. And dementia is a decline in mental ability that's severe enough to impact daily life. And so where MCI, it was cognitive impairment that didn't really impact the person's daily life. Once it does start to really impact their ability to care for themselves, their ability to interact in day-to-day life, then it likely is a type of dementia. And dementia is an umbrella term. That's why you see that umbrella graphic here on the screen. And there are different types of dementia. But it's really important to understand that dementia is not a normal part of aging. Of course, age is a risk factor of dementia, meaning as you get older, your risk of developing dementia increases. But getting older doesn't mean you're guaranteed to have dementia. It's not a normal part of aging. It's not something that we should ignore or just assume happens as we get older. It also is not just a disease of old age. We're seeing people at younger ages developing various types of dementia. We see people in their 50s, some even in their 40s and 30s, as young as 30s, and possibly even younger. There's a lot of new information coming out about dementia and the various types. But we need to kind of remove the notion of dementia is a disease of an older person, because it can impact somebody in their younger years. And it's important to acknowledge that, because, if a younger person is presenting some of the symptoms, they might not be taken seriously as maybe a potential sign of dementia because of their age. And we don't, of course, want that to happen. We want the person, to get the diagnosis that is true to whatever is changing cognitively in their brains. So again, dementia is that umbrella term, and the different types of dementia fall underneath. And when you logged into this webinar, hopefully a poll popped up asking you, what is the most common type of dementia besides Alzheimer's? We know Alzheimer's is the most common type. So what do you think is the second most common type of dementia? If you haven't had a chance yet to take that poll, I'm going to pause and let you do that now. So the options are vascular Lewy body dementia, which is LBD is the acronym. And then there's frontotemporal dementia, FTD, and then mixed dementia. So I'm curious to see, what do you think is the most common form of dementia? So we'll give you just a few more seconds to answer this poll. And it's not fair if you went out and Googled it. Looks like, if we can share the poll results out, that vascular, you all selected vascular as what you think is the most prevalent type of dementia. And then that was followed by mixed dementia. And then frontotemporal was slightly above Lewy body. So very interesting. Well, if we go to our next slide, you'll see kind of the breakdown here. So you were on the right track when you said vascular dementia. I know there's a lot of information on this slide, but I'll break it down for you. So we know, again, that Alzheimer's disease is the most common type of dementia. We don't have, of course, the perfect data for the prevalence of each of these types of dementia, because sometimes, somebody might not get a specific diagnosis, and only upon autopsy are they able to determine the type of dementia. But we are getting more advanced in the research and the science and the diagnosis process. So hopefully, as time goes on, we will continue to have a more accurate account of these various types of dementia. But we know Alzheimer's disease is the most common. 60 to 80% of all dementias in the US is Alzheimer's disease. And that's about just shy of 7 million people in the US. And memory loss is one of the most common early symptoms of Alzheimer's disease. Then vascular is also very common, and it often can occur along with Alzheimer's disease, and it's caused by damage to the brain because of a lack of blood supply, often because of a stroke or other vascular complications. And so what's interesting is 5 to 10% of all dementias are vascular only, but 40% of all dementias have a vascular component. So I think you were all on the right path when you said vascular is the second most common, because we see vascular often mixed with other types of dementia, very commonly Alzheimer's disease. So we can say that you were all right. The poll conclusion of vascular dementia as the second most common is true, because a lot of or almost half of dementias have kind of a vascular component. Then when we look at Lewy body dementia, that's about 20% of dementia cases. About 1.4 million people in the US have a diagnosis of Lewy body dementia, LBD. And this type of dementia has more motor symptom impacts, in addition to cognitive and behavioral changes. And we'll talk more about that here soon. And then frontotemporal degeneration, or frontotemporal dementia, FTD, there's about 50 to 60,000 people in the US with this diagnosis. And the most common form involves impacts to language and behavior. And there's often a younger onset of frontotemporal degeneration. So we see people earlier in life, in their 40s and 50s, being diagnosed with FTD. And so those 4 buckets we've covered, but then about half are considered mixed dementia. So that's having multiple types of dementia. And again, often there's that combination of Alzheimer's disease and vascular dementia make up that mixed dementia diagnosis. But what is really, really interesting is the research continues to evolve, and there are over 100 different forms of dementia, if you were to kind of break it down. And I definitely don't have time today to go deep into all 100 types of dementia. So we are going to stick to the ones that I have highlighted so far and spend the majority of our time there. So I did briefly want to touch on Alzheimer's disease because, again, it is the most common form of dementia, but I don't want to dwell here long because so much education and resources are dedicated to Alzheimer's disease, and rightly so, because it is the most common. But I just want to touch on it so that we can move on to the other types of dementia and give them some much needed attention as well. So again, the greatest risk factor for Alzheimer's disease is age. So the older we get, the more of a risk we are of developing Alzheimer's disease, and it develops because of these microscopic changes in the brain that happen over time. So we see research is finding that plaques and tangles develop in the brain. As you can see in the photo on the screen, the smaller picture is pictures of healthy neurons in our brain, and then the larger picture shows Alzheimer's disease in the brain. And so you can see the tangles that form that really prevent the nerves from being able to communicate with one another, and so it leads to cell death. And so it starts to impact the function of the brain. And we often see the signs of memory loss first, and it then progresses to impact other abilities to function in daily life, impact the person's ability to care for themselves, impacts language and communication. And because it is a progressive disease, there's no cure, but we are seeing more treatments, and I'm sure you've been hearing about them in the media, new types of treatments that help to delay the progression. And so that is exciting to see that happening. But again, because it is a progressive disease, an individual ends up passing away from Alzheimer's disease or complications thereof. So again, brief overview on Alzheimer's as the most common type of dementia. But now I want to shift our focus to Lewy Body Dementia, LBD. So when we look at LBD, it's also a progressive neurological disorder. It's characterized by abnormal protein deposits, which are called Lewy bodies in the brain. And the picture on the screen, it shows that Lewy body cell. And there are several subtypes of Lewy body dementia. And so there's kind of 3 pathways to diagnosis that a person would likely go through. So the first kind of categorizes it as Parkinson's disease dementia. So in this case, an individual would start with the diagnosis of a movement disorder like Parkinson's disease, and then later develop dementia. And so sometimes you hear it called Parkinson's disease dementia. And then dementia with Lewy body, there are kind of 2 pathways that fall under that category. In pathway 1, it starts out with a cognitive or memory disorder. Sometimes it's mistaken for Alzheimer's disease, but over time, there's more distinctive features that lead to the diagnosis of dementia with Lewy bodies. And then the third possible pathway first presents with the neuropsychiatric symptoms, which can include things like hallucinations, behavioral problems, difficulty with complex mental activities, and then leads to that diagnosis of dementia with Lewy bodies. So we'll talk about symptoms here in just a moment, but I bring up these pathways to diagnosis because I hear so often that it really is a diagnosis journey, and it takes individuals sometimes months, years to get an accurate diagnosis. And so if you're working with individuals that are are having some of the symptoms that we're about to go over, and it feels like it's taking a long time for them to get a diagnosis, to get to the right neurologist or specialist, that's not uncommon, unfortunately. And so it could be a bit of a journey to get that diagnosis. So just wanted to acknowledge that so people know that there's nothing wrong with you specifically. This is something that is fairly common. It can take a while to get an accurate diagnosis. So if we look at the signs and symptoms of dementia with Lewy bodies, LBD, you'll see a variety of symptoms. And again, not everyone that has Lewy body dementia will have all of these signs and symptoms, but again, it's important to know about them so we can help identify, okay, yes, it's time to seek out diagnosis specialist. So first is impaired thinking, so loss of executive function, things like planning, processing information, troubles with their memory, their ability to understand visual information. Also, any fluctuation in their cognition, attentiveness, or alertness. Also, we see commonly movement issues, so tremors, stiffness, slowness, difficulty walking, and sometimes for individuals, their gait, the way they walk, is an early indication that there is some issue, perhaps, with cognition or something happening within the body that is causing that change in gait. Also, we see changes in autonomic body functions like blood pressure control, temperature regulation. Somebody might get really hot, really cold. The ability to control their bladder and bowels might start to change. Visual hallucinations are also kind of a hallmark symptom of Lewy body dementia. It's more common in this type of dementia than some of the others. And so that's seeing things or hearing things that are not present. Often it's animals, children, or people. They might also hear things that are not there or mistake, the air conditioning kicking on for a dog barking, something of that nature. And I'll never forget one of my first clients that I worked with when I started at the Home Instead franchise, almost 12 years ago. He was an individual living with Lewy body dementia. And I remember that he often would hallucinate and see a dog in the backyard and think that it was his dog and try to get out of the back door to go rescue the dog. And so that is just a vivid memory. You'll never forget one of your first clients. And so that gentleman really sticks out to me. And it was one of my first interactions with somebody who was having hallucinations and delusions because of Lewy body dementia. Also for him, he had a lot of problems with his movement, and so was on a very strict medication regimen, of which our professional caregivers helped with. And it was almost, a matter of minutes where he had to take that medication to help him continue to kind of move about in a way that was comfortable. And so movement and those hallucinations, again, are kind of key symptoms and signs for this type of dementia. Also, you might see sleep disorders, acting out dreams in their sleep, having issues getting sleep, falling asleep, staying asleep, and then also behavioral and mood symptoms. You might see that the individual has depressive symptoms, or they're more apathetic. Maybe they have more anxiety or agitation. Maybe they're also having some delusions or paranoia of, somebody stole my purse, or there's somebody trying to break into the house, those kinds of things as well. And as I talk through some of these signs and symptoms, you might think, well, gosh, those sound like signs and symptoms of Alzheimer's disease too. And again, there is some overlap in signs and symptoms amongst some of these types of dementia. But again, there are several that are kind of hallmark symptoms for these various types of dementia as well. So again, it's not an all or nothing when it comes to signs and symptoms. And so we do need to take a look at what symptoms are presenting in the individual. And it can be really helpful to kind of keep a diary or a record of the patterns of the symptoms and the signs that are taking place, so that when you do go to the medical provider and they ask, okay, what types of things are you noticing? How often? What time of day or night does it occur? That you have that record to reference back to just make those appointments go more smoothly. Then we have some care tips. And again, these some of these are more general to all types of dementia. Don't argue, go with the flow. Sometimes arguing can escalate the situation. And so if you can, apologize, take the blame, or say, I'm so sorry you feel that way, and then redirect their attention, that can go a long way in helping to de-escalate a situation. Also, validating a person's emotions or responding to their distress is especially important in instances when there are hallucinations or delusions. You want to create a sense of safety. You want to help them feel safe. You might also need to give them some space at different points in time. So, again, if a person is hallucinating, think that they see a dog in the backyard, it's not really helpful to say, oh, there's nothing back there. Instead, you could say, oh, what does the dog look like? Again, you're validating that I understand you're seeing something, and I want to give you the opportunity to tell me more about that. I'm sorry you think somebody stole your purse. That's really upsetting. I can see why you're upset. Should we go look for it together? I'm sorry you think somebody is breaking into the home, but I'm here, I'm with you, I'm going to keep you safe. So again, sometimes these moments where we can reinforce, validate, provide that sense of safety and security, it can go a long way in responding to these dementia-related behaviors that are a result of the changes in the person's brain. So again, we want to try to identify patterns or triggers for certain behaviors. I remember one client that we worked with, every day at 3:00, the school bus would drive by, and it created a lot of agitation for the individual because they used to go pick up their kids at the school bus, at 3:00 every day. And so we simply at that time just closed the curtains so that visual just wasn't available to that person any longer. And that really took away her agitation at that point in time. So sometimes you have to get creative, kind of put your detective's hat on and look for the triggers that could be causing some of those behaviors. Also, if we can simplify activities as the person progresses through their diagnosis, to just meet them where they're at, meet their current abilities, and help them continue to live as independently as possible. So still offering them choice, even simple choices like, what would you like for breakfast? Eggs or cereal? Those kinds of things can go really a long way in helping them feel like they still have some control and agency in their life, even when the dementia might be taking some of those things away or feeling like it's taking those things away. Also specific to Lewy body dementia, because of the way it impacts movement, sometimes a person can get stuck, if you will. And so it can be helpful to use phrases like, let's go, to kind of trigger that mind-body connection, or come with me, and to, hold their arm and try to direct them, or, touch the thigh to kind of get that mind-body connection of, this is the leg we need to move next. Or sometimes counting, okay, 1, 2, 3, go. Or sometimes even music with a very distinct beat can help the person walk. Again, if they get stuck, those little strategies on how to keep them moving can be helpful. Also, with most types of dementia, having daily routines and schedules can be helpful. It creates predictability throughout the day. And then also, occupational therapists are a great resource for anyone with cognitive impairments or mobility impairments. Having them into the environment to help evaluate, what tools and resources can we bring into the home to help them remain safe and independent for as long as possible. So you can talk with a physician about a potential referral to OT, occupational therapy, to have that evaluation done within the home. So those are some care tips for Lewy body dementia. And I know I wish we had a whole hour for all of these different types of dementia, because we could go into such great detail. But we're going to wrap up on that one and transition now to frontotemporal degeneration, frontotemporal dementia, FTD, as our next type of dementia that we're going to zoom in on. And this type of dementia has been in the news recently because Bruce Willis has the diagnosis of this type of dementia, and his family has been very fairly open, I should say, about their journey, which I think can be so powerful to have somebody very well known to step forth and bring attention and awareness to this type of dementia. I think we've seen a lot of kind of progress just in the education around this disease. But FTD, it's a cluster of complex disorders. You know, sometimes it's referred to as frontotemporal dementia, frontotemporal lobar degeneration, Pick's disease. So there are various kind of types of FTD, frontotemporal degeneration, when you look at it. And we do see that FTD symptoms do differ from Alzheimer's symptoms. You know, FTD, we see often changes in behavior and personality, language, movement changes. We also see often, as I mentioned earlier, a younger onset. Whereas in the case of Alzheimer's disease, we see often memory loss, confusion, issues with visual spatial relations, and often a later onset. Now, I will say, with Alzheimer's disease, you do have younger onset as well, but more commonly, we find FTD symptoms start to present typically in a younger audience. So again, somebody with FTD, we'll get into the symptoms later on, but they often are kind of categorized into a subtype of FTD. So the most common one is there's a lot of complicated words to say in today's webinar, so thank you for bearing with me. Progressive behavior personality change behavioral variant FTD, which is abbreviated as BV FTD. Progressive language change primary progressive aphasia, which is abbreviated as PPA. And then progressive motor function movement change. And that is kind of the third category. So that encompasses a few things, like motor neuron disease and a few others. So again, it can be helpful to know, okay, even within FTD, can we get a more specific diagnosis? What type of FTD does my loved one or my care partner have, so that I can best support them, so that you can best support them. So when we look specifically at that most common type of FTD, the behavioral variant FTD, we'll see, symptoms specific to that type of dementia. So again, this one is the most common form, and we see it called FTD because the frontal lobe of the brain, the prefrontal cortex, that's where we see the impact of the dementia most prevalently, which impacts our ability to make decisions, and it impacts our reasoning abilities, our control over our behavior, our problem solving, our ability to concentrate and keep our attention focused, the emotional control, also our safety awareness. So somebody might have decreased inhibition. They might take on more risky behaviors. They might not initiate action, or they might have issues also with their physical movement and executive function, like planning and organizing. And so, again, if we're seeing these types of symptoms in an individual, we need to bring them forth to a medical provider. And on this next slide, again, going into more of these signs and symptoms of FTD, these are the things that we see commonly with FTD is apathy. And this is one of the more common first symptoms that we see. So apathy is an indifference or lack of interest in what once was a meaningful activity to them. And so I've heard family caregivers talk about how, kind of out of nowhere or over time, their loved one just, they had changes in their mood and their apathy, and they were seeing these changes that were very uncharacteristic, and it was very confusing to the family. And so they thought, well, we think something's wrong. And again, they also, like LBD, have often a long kind of journey to diagnosis. So they might start out going in for maybe what they think is depression. Maybe their loved one just has depression, and that's why we see the onset of these symptoms. And then, as the process goes on, they realize actually there is some dementia happening, and eventually get to that diagnosis of FTD. Another early sign is behavioral disinhibition. So again, somebody might start to act out of character. Maybe they have a loss or lack of restraint. And so maybe what once was a social norm for them, now they've kind of thrown it to the wayside, and they're acting maybe more inappropriately or more impulsively than they ever have before. They might make uncharacteristic comments that are rude or offensive. They might start to ignore people's personal space. They might start doing things like shoplifting or reckless spending, or often, again, matters of finance, or where sometimes the first signs and symptoms start to occur. Maybe they're buying a bunch of stocks or selling money from their retirement fund, or taking out money rather from their retirement fund, or doing some things that are very uncharacteristic of them, and a little bit kind of what would be seen as reckless in terms of their finances. So that can be, a sign something else is going on. There might start to be some inappropriate sexual behavior taking place, or aggressive outbursts that were not common before. So really those changes in behavior. We also can see deficits in executive functioning, again, that poor decision making or judgment. Perhaps they're having more issues problem solving or organizing. I know one gentleman who was living with dementia. He spoke at an event that I was at, and he was in a leadership role where he was regularly reviewing the financial statements of the business, and he started to notice it was a lot more confusing. The numbers weren't adding up, and that was an early sign to him that something was going on. And he kept it hidden for quite some time, and then, eventually things came to light, and he went through the diagnosis journey, which did take a while because he was kind of in that younger onset category. But for him, those kind of problem-solving skills, organizational skills, those were things he started to notice first. We also see a loss of sympathy and empathy. Maybe a person used to be warm and empathetic, have a lot of concern for others, and all of a sudden that has kind of gone away. That could be an early sign or symptom. Also, we can see changes in eating habits or diet, maybe excessive or compulsive eating, or maybe there is increase in drinking or substance use that is different than their behavior over their life course. Also, they might have new behaviors or routines that are more compulsive or ritualistic types of behaviors that they're doing over and over. So again, these are types of signs and symptoms that could present. A person might not have all of them, but definitely want to be at a heightened awareness if these are occurring. And again, recording those symptoms, making note of when they're taking place or when they started, can be really helpful going into a diagnosis, or a medical conversation for hopefully then a diagnosis. And you'll see at the bottom, I have some links. I've done some kind of webinar interview style chats with experts on these various types of dementia. So if you want to check those out, please download the slides, and then you can click those hyperlinks and it'll take you right to those videos. So moving on to some care tips for this type of dementia. I think what can be helpful is to evaluate expectations. Sometimes family members think that the individual is doing these things on purpose. And it's important to reframe that. Often it's the dementia that is changing the brain that is causing them to act in a different way. And so they're not necessarily doing it on purpose. I think it's also important to evaluate, is this behavior hurting themselves or others? Because sometimes it can just be annoying, for lack of a better word, especially if they're repeating the same thing over and over. But if it's not hurting anyone, maybe you just need to kind of change your expectation and your mindset on approaching that response maybe a little differently next time. But if it is hurting themselves or others, then it does need to be addressed. Sometimes family caregivers and individuals stop going out into public because outings start to become more complicated, or they're afraid that the individual might act inappropriately. And so it can be helpful. You can see on the screen the AFTD, the Association of Frontotemporal Degeneration, they have these cards that say, please pardon my language or behavior. And you can share that with somebody when you're out in public to help them understand, okay, this person's not doing this on purpose. There is an underlying condition. So when there is some of the compulsive behavior, it can be helpful to assess it, identify, are there any triggers? Sometimes routine can help. I mentioned that routine is good for all types of dementia. And then also, if possible, engaging in physical activity, especially if an individual is still, young onset, often they are physically fit, but their brain is deteriorating. And so if you can help them stay physically active or walk, it can be a good activity. A safe wandering, maybe in a secure location, can help kind of walk out some of the excess energy that they have. Also, you can modify the environment, minimize any noise or stimulation or distraction, reduce clutter, and sometimes simplifying the social situation can be helpful. Instead of a big family gathering, maybe it's just a couple of people to interact with in a side room at a time, instead of being out in the larger crowded area. So again, a few care tips. They can be helpful across dementias, but specific to FTD, those can be helpful. Okay, moving on to vascular dementia. So again, this is often a secondary form of dementia found in that mixed dementia category. It can also be referred to as vascular cognitive impairment, VCI. And vascular dementia, again, is caused by that decreased blood flow to parts of the brain. It could be due to a series of strokes, maybe small strokes, TIAs, sometimes they're referred to, or over time, other issues that can lead to a decreased flow of blood to the brain can impact the person's cognition. And that stepwise decline can occur for some people, again, in those series of strokes. They might have a mini stroke and they have a little decline. After the next mini stroke, a little more decline. So that's why that kind of stair decline can be common amongst those with vascular dementia. But really, any condition that damages blood vessels anywhere in the body can cause changes that are linked to vascular dementia. So, those that have risk factors like hypertension, diabetes, heart disease, those at an increased risk of stroke, we want to make sure that all of those chronic conditions or health conditions are being effectively managed, and that we help encourage them to keep up with their medications and their doctor's appointments so that we can reduce the damage to the brain in the long term. So signs and symptoms of vascular dementia. Again, these symptoms do vary quite greatly depending on the severity of the damage to the brain and the various parts of the brain that are impacted by the damage. So we've talked about apathy and depression and mood changes. This can also occur in people living with vascular dementia. Some people that have loved ones with this disease have said, day by day, there can be changes in my loved one's signs and symptoms. One individual shared that in her mom specifically, she noticed a change when there was a spike in her blood sugar. So little things could potentially impact the signs and symptoms. Also confusion and disorientation. Again, depending on the areas of the brain that are impacted, the individual could have troubles with speaking or understanding, speech. You might see increased anxiety in some individuals. Those that have damage to the brain as a result of a stroke, they might have paralysis or numbness on one side of the face or the body that further complicate any sort of cognitive impairment. So individuals might have difficulty walking, and they might have issues with balance. And so again, the signs and symptoms of this type of dementia tend to, again, correlate with the damage done to the various areas of the brain, and again, can be mixed with other types of dementia. So care tips specific to vascular dementia. Again, we want to remember the person's not doing it to whatever it is on purpose. Likely it's due to damage of the brain. And also, what works one day might not work the next in terms of calming someone down or redirecting them. But it's important to encourage care partners, caregivers, not to give up. And to continue trying to maybe de-escalate the dementia-related behavior or make sure that that person's needs are being met. Again, that apologize, take the blame, that can go a long way, especially when you're trying to avoid arguing. Giving the person space for a little while and reapproaching them with the activity or the choice that you're trying to offer. Also being clear and concise in communications, especially if that individual has issues processing communication and speaking back. Sometimes even just 10 seconds pause to allow them to process the information and to speak out a response can go a long way. Also, this goes for all types of dementias. Engaging the person in activities that are personalized and meaningful can be a great way to provide purpose and meaning to their life, and also integrate into their activities of daily living, and making them providing opportunities to perhaps redirect from any dementia-related behavior. Also offering comfort items or activities if there are moments of anxiety. And again, wearing that detective's hat, remembering that, behaviors related to dementia-related behaviors are often, there's often a purpose to them. They're trying likely to communicate something to you or to share a frustration or a struggle. And so we need to try to get to the underlying reason behind that dementia-related behavior so that we can address it and provide the best care possible for them. All right, and then finally, mixed dementia, the last one. And it only gets one slide because, again, because it's mixed, the condition will likely take on the signs and symptoms of the types of dementia that are mixed together. So again, Alzheimer's is the most common type of dementia, so often you'll see that mixed with another type of dementia. There's that combination of Alzheimer's and vascular disease that is more common. And as we learn more and more about dementia, we're finding mixed dementia is more common than we previously believed. And sometimes it's not clear until autopsy. And so I believe we'll continue to learn more over time. It can be challenging for a family member and an individual if there is a mixed dementia because it can be hard to know, okay, where do I go for resources or support if I have both Alzheimer's disease and vascular, or Lewy body dementia, and another type of dementia. But in a few moments, I'll share a resource slide of places we can direct individuals and families so that they can get much needed help and support. And one last thing on mixed dementias, what's interesting is those age 85 and older are more likely to have some form of mixed dementia. So again, as we get older, our risk of developing Alzheimer's or another type of dementia increases. But I think really good news for all of us is we are starting to learn that there are a lot of things we can do for our brain health over our lifespan to help reduce our risk of all of these types of dementia. And I did want to just end our time together today with a quick slide on those 6 key areas that we can be proactive at any age to help reduce our risk of developing cognitive decline. And even after a diagnosis of a type of dementia, focusing on these 6 areas could go a ways in perhaps delaying some of the progression or improve quality of life for that individual. So regular exercise is the first one. Some argue that that's the best thing you can do for your brain, and it's more so get moving. It doesn't have to be those traditional kind of exercise activities, but even walking on a regular basis is really good for your brain. And if you can mix in some strength training and some balance, even better. Also, eating healthy. We know now that the MIND diet and the Mediterranean diet are the most effective in reducing the risk of cognitive decline later in life. We also are learning how much sleep and relaxation is so important for our brain. At night, when we're sleeping, the brain gets to kind of do a dump of all the toxins. And so if we're getting quality sleep, it's really good for our brain. Also, social connection, maintaining social connection even after diagnosis is so important. Those conversations that we get to engage in are really good for our brain. And then if you could pair it with things like exercise or eating healthy, that's a double bonus. Also, continuing to engage your brain in ways that are meaningful to you, whether that's learning something new, engaging in a regular card game or book club, or even the brain games that we all have heard about, like Sudoku or crossword puzzles. Those can be great, and a mixture of all of those things are even better. And then finally, managing stress. We know that the stress hormone cortisol can be damaging to our brain. And so if we can reduce our stress over our lifetime, then that is good for our brains. So I did not want to close out the presentation without acknowledging there is a lot we can do for our own brain health over our life course. And then finally, I wanted to share some resources with you all, because I think after a diagnosis, so often I hear families talk about how lonely and isolating their experience was, and it doesn't have to be that way. A lot of people know about the Alzheimer's Association. Their website, alz.org, has a lot of helpful information. They also have a 24/7 helpline, and I work closely with them on a national level, and they talk often about how they will help people of all types of dementia, not just Alzheimer's disease. So if you ever, in the middle of the night have a question, reach out to their hotline. Then there's also 2 organizations specific to the types of dementia we've covered. The Association for Frontotemporal Degeneration, AFTD, has a fantastic website with resources and information and support. So if that is the specific diagnosis, going to that website specifically will open up a world of information and knowledge and support. Same goes for the Lewy Body Dementia Association, LBDA.org. Their website has great information specific to Lewy body dementia. And then another great organization, I happen to be on their care advisory board, is HFC, Hilarity for Charity. They have online support groups and respite grants. And so their website, wearehfc.org, has some great support resources. The Dementia Map is a kind of just a great website with a lot of great support and resource information. So dementiamap.com is that website. On Home Instead's YouTube page, we have some great care tip videos on how to live well and safe at home if you have dementia. And then I also host a podcast called Caregiver Chats. You can find it on Apple, Spotify, or wherever you podcast. And many of the topics that we cover in the podcast touch on Alzheimer's disease and tips, resources, and support for caregivers and care partners. At Home Instead, we also have a really helpful and it's just a very involved Facebook community at Remember for Alzheimer's Family. And then I love Teepa Snow. She has some great resources on her website as well. And then a great book, David Troxel has written a series of books on the best friends approach to care. So as a care partner, you can look to that for more tips and care resources. And then, of course, if you're looking for home care to support an individual living with dementia, at Home Instead, we do have our website there, homeinstead.com, and our care professionals are trained on Alzheimer's and dementia care. And so getting that respite, that break, that support for the family caregiver or care partner can be really helpful, because we see high rates of burnout amongst caregivers or care partners of those living with dementia. So we want to make sure that those caregivers are taking good care of themselves while they care for the person they're supporting. So with that, I know we have just a few moments for questions. I want to thank you all so much. Again, I wish I could have spent an hour on each of these types of dementia alone, but at the very least, hopefully this gives you a place to start and then some resources on where you can go to learn more.
Thank you so much for the presentation, Lakeland. We don't have that much time left, so if you have to hop off, we understand. But I do want to get to some questions here. A lot of love for Teepa Snow. I love her too. She was my introductory guide with her different gemstones, levels of dementia. So a lot of love for her here. One of the common themes that I saw coming up was really about accurate diagnosis and, you know, getting second opinions. How can we approach getting second opinions? If the diagnosis is unclear, it doesn't seem right. Are the tests more accurate now? So can you speak to that a little bit?
That is a great question. And it's actually something I'm covering on my podcast in the next episode. So be sure to tune in. You know, diagnosis, I think, has come quite a long ways in a short period of time. And if you compare Alzheimer's and dementia to cancer, you know, we know a lot more about cancer now than we did decades ago. And Alzheimer's is kind of behind cancer, you know, so we're starting to finally learn more and more about Alzheimer's and dementias and how we can accurately diagnose. And so I know that the Alzheimer's Association's International Conference just took place in July, and that's when the science community really comes together and shares the latest science. And I think what's exciting is we're starting to see more diagnostics that are coming out or that are kind of in the going through kind of the clinical trial phases for things like a blood test that would be able to help with diagnosis. So something like that, a blood test, is more accessible than something like a PET scan that you need a giant machine for, and you'd have to be, you know, near that machine or travel to that machine to get diagnosis. So I think that we have come a ways. We still have a long ways to go in terms of diagnosis, but getting to a specialist, a neurologist, a geropsychiatrist, a geriatrician, somebody that is more specialized can be helpful in your diagnosis journey. You know, we are starting to see more general practitioners or kind of your family doctor being equipped with more kind of simple tests to help identify if there could be cognitive issues and help with some of that diagnosis, but often then there is a referral to a specialist. So I would encourage you to start with that family care doctor or primary care doctor to express your concerns and then ask, okay, what could be the next steps? And unfortunately, we live at a time where there's just not enough geriatricians and people in the medical field that specialize in aging, the aging population and kind of the diseases of the later years of life. But I'm hopeful that with improved diagnostics that we'll be able to get people a diagnosis quicker. And I will add, I know we're at time. People sometimes ask, why would I get a diagnosis if there's no cure? And I think that's the wrong way to look at it, in my opinion, because if you're able to get a diagnosis, then you're better able to plan for the care and support that that person will need over time. And also, you'll be able to plan ahead while that individual can still hopefully contribute to putting that plan together, making their wishes known on how they want to be cared for. And there's also a lot of people living well with dementia. Of course, it is a devastating diagnosis, but there's a whole community of people that are living well with the diagnosis, that are kind of making lifestyle changes that really are improving their quality of life. So tapping into organizations like the Dementia Action Alliance. It's a group of individuals living with the disease that are advocating for living well with dementia. I think also plugging into those communities can be really helpful. So sorry for my very long-winded answer, but that is a great question and one I hear often.
No, that's great. Thank you so much. We are at time, unfortunately. I know some of these questions did get answered during the course of the presentation, which is always great. And there's some great resources and places for caregivers to connect as well that you've provided. So thank you all for your participation today, and a special thanks to Home Instead for bringing us this session. As a reminder, your application for certificates is at the top of your screen. Just click Add Membership. That does not require you to have a membership with ASA or to any of the accreditation boards, because as we know, state boards can accept national accreditation boards. So you don't have to be a member. That's just the way for you to select which certificate you want and enter your license number, which will be listed as a membership number. If you do have any other questions, you can contact us at institute@asaging.org. And you can also visit our website for details on upcoming webinars, including Encore Careers, Navigating Work and Purpose in the Second Half of Life, which will take place on October 2nd. Thank you again, Lakeland, and everyone here today. We appreciate you being a part of our community. Have a great one.